Hello all, welcome to Oncology Spotlight Expert Insight. I am Yüksel Ürün, your host for today. I am medical oncologist at Ankara University, Turkey, and interested with GU oncology. Just after the ASCO GU Cancer Symposium, I will be discussing today with you the KEYNOTE B15 study, which is the new Adjuvant and Adjuvant enfortumab vedotin plus Pembrolizumab for patients with muscle-invasive bladder cancer who are eligible for cisplatin and randomized open-label phase 3 study presented by Matt Galsky. And in this study, actually, this is 1:1 randomized for enfortumab vedotin plus pembrolizumab, and in control arm we have a standard of care, which is cisplatin gemcitabine for patients. And after the radical cystectomy and pelvic lymph node dissection, patient continue with enfortumab vedotin and pembrolizumab. And of course, in the chemotherapy arm, the standard was observation. And the primary endpoint of this study is event-free survival, and key secondary endpoint is overall survival and pathological complete response rate. Actually, in this study, event-free survival is being primary endpoint, and which is one of the frequent endpoint used in previous study too, and it's evaluated for ITT population. And of course, in this study, and more than 800 patients undergo the randomization. In one arm, 400 for EV Pembro and 400 for cisgem, and almost 90% of all patients in both group go to the surgery after the neoadjuvant chemotherapy. The baseline characteristic of the patient is well balanced, and which is we all know for patient with bladder cancer, mostly male, and medical median age is around 66, and most of the patients present with ECOG 1 and ECOG 0, and most of the patient is T3, T4 diseases. There is almost no N2 diseases. And of course, the study met its primary endpoint, which is event-free survival. At the 2 year, it's like a 13% absolute gain for event-free survival. And in GemCis arm, the median is like almost 4 year, and EV Pembro is not reached median, but at 2 years, there is almost 80% of the patient in EV Pembro arm and 66% of the patient in GemCis arm is event-free. Of course, and also in OS data, in 2 years, there is absolute 5% gain with EVP, and hazard ratio for OS is 0.6. And of course, also PCR, pathologic complete response, is one of the endpoint for us in patient with muscle-invasive bladder cancer. And for many years, we start with 40%. And now in this study we have 55% complete response rate, which is really something we always wait for patient with bladder cancer. Of course, this is have one of the practice change trial from the ASCO GU, and of course there is several ongoing critics in this. Of course, patient in GemCis, the number of patients getting adjuvant immunotherapy is less. Of course, there is the toxicity, but well balanced between two arms. But what we can say for this study, and also we know in patients with cisplatin ineligible, also EVP improve event-free survival and the overall survival. With that, it seems EVP could be one of the candidate regime for patients with muscle-invasive bladder cancer, regardless of cisplatin eligibility. Of course, we cannot make cross comparison because of every study has different patient population, but when you compare with the other trial like a Niagara, KEYNOTE 905, regarding the event-free survival and overall survival, both EVP provide almost 80% event-free survival and more than 80% 2-year overall survival. So from the ASCO GU this year, this bladder cancer trials, I believe will be one of the standard of care in the coming days. Of course, the accessibility remain the problem across the different country. For example, in Turkey, I don't expect soon it will be approved for reimbursement. But if it became accessible, it will be one of the standard of care for our patients. We will discuss LINESPARK-011 study from the ASCO GU recently presented by Robert Matzert at ASCO GU San Francisco. Actually, in this trial, patient who already received IO-based treatment, whether adjuvant treatment or IO plus IO, just randomized to Belzutifan plus Lenvatinib or compared with the cabozantinib alone. In this study, almost 750 patients randomized both arm, and of course, at least, let's say, almost 70% of patients treated with the adjuvant treatments, and one out of 4 patients treated with at least 2 lines of the treatment before the randomization. And the overall, when we saw the efficacy result of this study, Belzutifan plus Lenvatinib show improvement in progression-free survival comparing with the cabozantinib. In cabozantinib arm, the PFS is 10.6 months, and in Belzu-Lenva arm, it's like a 14.06 months, and the hazard ratio is 0.74 for progression-free survival. And of course, in this setting, more than 50% of overall response rate. This is also very important for us because even in first line of the treatments for several years, we have around 30% of the overall survival, overall response rate. But with combination of the IO plus IO or IO plus VEGF, we go from 40% to almost 70%. Now, in second and after the progression with IO-based trials, have 52% of overall response rate. It's really striking for us. Of course, OS data is still immature, not yet significant, but the PFS tails suggest that durable control in subset of the patients. And of course, the benefit of treatment across IMDC risk group, especially in patients with favorable and intermediate diseases, in patients with poor risk. Of course, the number of patients is not that much. Maybe it's not possible to make definitive conclusion, but what we can say in this line of the treatments, Belzutifan plus Lenvatinib improve progression-free survival. Of course, the adverse event is something we expect, both Belzutifan related and Lenvatinib related. Of course, the most common one, which is with Belzutifan, is anemia and hypoxia. Of course, we have several other trials in post-PD-1 progression. Of course, we have a durable response, but it is limited. And we have CONTACT-03, LINESPARK-005, LenCabo, and LINESPARK-11 now. And for those all trials, duration of response is almost 2 years with LINESPARK, but of course, still we need longer duration of the response for our patients. But definitely, it will be one of the options for our patients who post-PD progression in patients with kidney cancer. We will discuss LINESPARK-22 study from ASCO Genitourinary Cancers Symposium, which is presented by Tony Shueri. And in this trial, in patients with operated kidney cancer with intermediate or high risk of the recurrence, or patient with M1, no evidence of diseases, randomized with standard arm of the Pembrolizumab, which is already we know from 564 study, which is improved both disease-free survival and the overall survival, and became standard of care for patients with high risk of the recurrence. And in the control arm, we have again Pembrolizumab, but this time combination with Belzutifan, which is HIF2 inhibitor. And the expectation is adding Belzutifan top on the Pembrolizumab, whether will improve oncological outcome in this group of the patients. And of course, the primary endpoint of the study is disease-free survival. And in 2 years after the 28 months of the follow-up. It's associated with 7% of absolute risk reduction and improve disease-free survival, and hazard ratio is 0.72. And of course, still it is not ready for overall survival. It is immature, but it's met its primary endpoint. Of course, also having overall survival benefit will make it more clinical and practice changing for us. But for now, we can say adding Belzutifan to the Pembrolizumab improve disease-free survival in patients with kidney cancer who are at risk of the high risk of the recurrence after the nephrectomy. And of course, whenever we use any treatment in patient with kidney cancer, in other adjuvant trial, toxicity always is one of our concern. Of course, it's like 40% of patients have grade 3 toxicity, 10% led to treatment discontinuation, and which is very important concern for us, because whenever you go to the adjuvant treatments, the patient tolerance, patient aim, patient willingness to the continued treatment is, of course, always affected by treatment toxicity. For now, what we can say, it is very important data for us. Adding Belzutifan to the Pembrolizumab improve disease-free survival, but not having OS benefit yet. It's one of the concern. Of course, we need more longer follow-up data. Today we will discuss abstract number 16 from ASCO Genitourinary Cancers Symposium, which is presented by Maha Hussein. This is BRCAAway trial, which is overall survival from the phase 2 trial of abiraterone olaparib or abiraterone plus olaparib in first-line metastatic castration-resistant prostate cancer with DNA repair defect. By note, in this study, patient with BRCA1, 2, or ATM alteration included in this trial. In arm 1, abiraterone, in arm 2, olaparib, in arm 3, olaparib and abiraterone combination used, and upon progression, crossover was permitted for first 2 arms. And actually, the primary endpoint of the study is radiographic progression-free survival and secondary endpoint in overall survival. In oncology, this is one of the fundamental questions for us, whether in patients with metastatic diseases start with combination or use this agent in sequence. And of course, the question is whether combination of the treatment will improve oncological outcome, and the second, whether this combination will bring more toxicity or not. So it is really one of the very important, although this is small size of the study, the question is very clinically very relevant question. And when we come to the efficacy, combination arms show better overall response rate, progression-free survival, and overall survival too. When we come to the progression-free survival, in ABI arm, the median progression-free survival was around 8.6 months. In olaparib arm, it is 14, but in combination, it is more than 3 years, 39 months of the median progression-free survival, and the hazard ratio is 0.3, and which is really very effective and very significant trial. Of course, with crossover, you cannot get same amount of the benefit. So we cannot say using this treatment in a sequence will provide the same benefit. When we come to overall survival, actually, again, with ABI plus prednisolone, it is 28 months. With olaparib, it is 37 months. And with combination arm, it is more than 5.5 years. It's like a 68 month of the overall survival. Again, comparing with ABI prednisolone or olaparib, is hazard ratio between 0.39 and 0.51. So what we can say, in patient with selected mutation like a BRCA1, 2, and ATM, in patient with metastatic castration-resistant diseases, starting with combination provide longest survival. Median is more than 5 years compared to either agent alone or sequentially. So what we can say, and also the data from other combination study in patient with HRD mutation, especially BRCA1, 2, and the ATM, starting with combination of the PARP inhibitor and androgen receptor pathway inhibitor, seems associated with better survival. And as I said before, although this is one of the phase 2 with small size, it is like a proof of concept and shows us significant efficacy, significant benefit. So I think this is one of the important and clinically practice-changing study from the ASCO Genitourinary Cancers Symposium. Thank you for the listening and hope to see you soon in the next one.